the coronary arteriography. See, coronary arteriography, this will tell you about, or this will give you the picture of the lumina. See, in some of the elderly patients, what will happen is the Agatston score may be very high, but the lumina will be absolutely normal. Why and how? Because the calcium which is being deposited is accumulated within the vessel wall, right? That is the reason why the Agatston score may be high, but the lumen may be normal, and that assessment of the lumen can be done by the coronary arteriography. So this diagnostic method outlines the lumina of the coronary arteries, and it can be used to detect or exclude, right? It is used to detect or exclude serious coronary obstruction, right? Serious coronary obstruction. So this is what is the importance of the coronary arteriography. However, this coronary arteriography provides no information about the arterial wall, right? It will not give you any information about the arterial wall. So it will just give you only information about the lumen, right? So it will not tell you if there is any development of atherosclerosis within the vessel wall, right? But if the atherosclerosis is occupying the lumen, that can be detected by the coronary arteriography. But if the atherosclerosis does not encroach the lumen, the coronary arteriography cannot detect the atherosclerosis. So if you see the distribution of the atherosclerotic plaques, this atherosclerotic plaque, it is scattered throughout the coronary tree, right, and tend to occur more frequently at the branch points. See, the branch points are considered to be the area where there is increased force of blood or increased pressure areas. Which one? The branch point areas where there is rupture of the endothelium. So once there is rupture of the endothelium, there can be accumulation of your platelets, accumulation of the blood cells, accumulation of the fat, where there can be formation of your atherosclerotic plaque. So branch points are considered to be the more frequent areas where there will be presence of atherosclerotic plaques. And whenever the atherosclerotic plaque develops, remember, the plaque initially it starts within the intima. After the intima, the plaque, it goes to the media, and after the media, right, then the plaque initially will have a bulge outside. So initially there will be outside bulging. So you see here, when the plaque is present within the intima and as well as within the media, the lumen appears to be normal, right? Now the development of the atherosclerotic plaque within the intima, within the media, and finally what happens is it encroaches the lumen, right? Finally it encroaches the lumen. So until the atherosclerosis is present within the intima and as well as media without encroaching the lumen, where there is only outward bulge of the artery, right, where there is outward bulge of the artery. So this is considered as remodeling of the vessel wall. This is considered as the remodeling of the vessel wall. So later what happened from the vessel wall, right, the plaque, it reaches the lumen and then the lumen size will be narrowed. So that is about the distribution of the atherosclerotic plaque. Now you also need to know about the indications of coronary arteriography. Is it like all the patients with ischemic heart disease, do they require to undergo coronary arteriography? That is what is being said by the ischemia trial. So ischemia trial informs decision making about referral for coronary arteriography in patients with stable ischemic heart disease and an ejection fraction more than 35%, even in the presence of moderate severe ischemia on non-invasive functional testing. So which particular trial will tell you that the individual has to undergo coronary arteriography or not? That is by your ischemia trial. So according to this particular trial, the coronary arteriography is indicated in patients with chronic stable angina pectoris who are severely symptomatic despite medical therapy, and these patients, they are being planned for revascularization, right? These patients, they are being planned for revascularization either by PC or CABG. In this individual, you need to do coronary arteriography. The second scenario is patients with troublesome symptoms, right? Patients with troublesome symptoms that present diagnostic difficulties in whom there is need to confirm or rule out the diagnosis. Okay, so troublesome symptoms where the diagnosis is uncertain by non-invasive tests. In them, you go ahead with the coronary arteriography. And third indication is patients with known or possible angina pectoris who have, right, who have survived cardiac arrest. In them, you go ahead with the coronary angiography, right? And fourth important scenario is patients with angina or evidence of ischemia on non-invasive testing, right? Evidence of ischemia on non-invasive testing with clinical or laboratory evidence of the ventricular dysfunction, right? Laboratory evidence of ventricular dysfunction. Okay, so patient having angina and there is also ventricular dysfunction on the 2D echo, that's an indication that you have to do the coronary arteriography. So the first important investigation, refractory to medical management and planned for revascularization. Second, troublesome symptoms and diagnostic modalities uncertain about the ischemic heart disease. Third, presence of survived cardiac arrest in a case of angina pectoris. Fourth, laboratory evidence of ventricular dysfunction in the case of the angina. So all these four are the indications of doing the coronary arteriography.